Dear friends, today I am going to share my experiences with you regarding treatment of polio deformities. Also, what is post-polio syndrome and how ILIZAROV and HEXAPOD can be a great help to treat these things. Also, the title to this presentation has been given as Forgotten Brothers. Why forgotten? I'll explain you in the next slides. Dear friends, this is not just a presentation. It is His blessings and 16 years of faith and surrender of these patients who are suffering from polio and post-polio syndrome. It is my journey. We started from plaster and then ILIZAROV and HEXAPOD. You can see with the help of plaster, earlier we used to treat these flexion deformities of the knee by doing an extension osteotomy. The disadvantage was it was only possible in young patients. It was only benefited in those patients who are having very thin thighs, and collateral damage in the form of more of recurvatum or undercorrection or some unwanted varus or valgus, they used to be present, along with sometimes rotation of the fragment distal in the plaster could not be controlled. These all things added on to more comorbidities sometimes than good. So we shifted on to ILIZAROV, which was much more precise, and we could control the deformities, their corrections in a much better way. After that, we could control these osteotomies, their directions, with the help of HEXAPOD. It was much more precise and very easy. Once we were used to it, we started applying it supracondylar, leg, ankle, foot in the same patient at one time or at different times whenever we wanted, or we found the need to correct those deformities. I told you I have given the name as Forgotten Brothers, these poliotic patients. Why polio patients? They are forgetting the orthopedic surgeons. We think polio has been eradicated. What about post-polio deformities? These are the recent pictures, 2014. And now you can see how the children are developing contractures, how they have started using their hand on the thighs. These children will become adults and somebody will have to take care of them. And as we moved from plaster to HEXAPOD to multiple of them, along with ILIZAROV, we also moved from plain x-rays, only 2 x-rays they were taken, knee and hip, to full length x-rays, frontal plane as well as sagittal plane. So we wanted to be more accurate, more precise. After that, we started getting 3D CT scans so that we can look at the deformity from all the angles, compare it with both the sides and see what are the directions of the plateau, what kind of femoral condyles we are going to deal with, what are the effects which have been left, and sometimes if these patients are having fractured neck of femur, in which some kind of implants they are there, how to pass the shunt pin proximally. Also, we find out that if we can find out what is the MPTA on CT scans, what is the neck shaft angle, what are the malalignments, we become much more wiser in treating these patients. Another thing recently which we have added is 3D model of the lower limb, which we are going to do. This will tell us what kind of deformities are at the knee, at the thigh, how much contractures they are there, and it will give more of a real look about those bones which we are going to deal. A big thing which helped me out was MacBook Pro, which I purchased only and only for this, because it is having a horror software with which you can calculate what are the angles of the lobe, where are the deformities. After this, now we have started using Bone Ninja app, with which we can virtually do certain osteotomies, see how they will look, how will they affect the other joints, etc. Dear friends, we call them as forgotten brothers because most of these patients, they come to our OPD daily. We just, like this girl, young girl, she comes for consultation, that can anything be done for her? Another girl who says there is shortening of 2 centimeters in the involved lower limb in spite of multiple operations already which have been done. Another person who says he is unable to bear weight now and he is unable to walk few steps and he thinks he will be on wheelchair after some time. Another patient is 47 years of age, gets tired and wants, can you help me please? Such kind of severe deformities of the hip, knee, lower limb, the patient who has never walked. If these patients they come, most of the time we do not have much of answer to treat them. Hand-thigh gait, very common gait of these patients. Another hand-thigh gait in which even the length is also an issue which has to be addressed. Another patient who is walking without hand-thigh gait. Should she be touched? Because everything is compensated. Another VIP patient, VIP in the sense he is our doctor colleague, he is MD Medicine, 29 years of age. In 2017 he came to us and he said, can he walk on the poliotic lower limb without the help of a stick? I'll answer these questions in my coming slides. Another patient, big caliper, using all the 4 limbs for walking. Another patient, using all the limbs, 4 limbs for walking. 38 years, slightly obese lady, hand-thigh gait. And a 59 years of age male. All these patients, they come to us in the OPD, and most of the time we do not have answer to their problems. What do we do most of the time? We advise them vitamin D, B12, calcium. We prescribe certain analgesics, some physiotherapy, yoga, AFO, KFO, caliper. Patient most probably will not turn up again because he or she knows we do not have much to offer to their ailment. Another thing, One very important question which we forget to ask, and it took me more than 7 years to start asking this question, that are you deteriorating? And to my surprise, more than 70 to 80% of the patient said yes, they are deteriorating. And it was a gradual deterioration. At what speed? Might be 1 year, few years, few months. And what is the diagnosis if they say yes, they are deteriorating? The diagnosis is post-polio syndrome. Post-polio syndrome, it is a condition which affects polio survivors years after the recovery from an initial acute attack of the poliomyelitis virus. Post-polio syndrome is mainly characterized by new weakening of the muscles which were previously affected by the polio infection, and in muscles that seemingly they were unaffected. The severity of residual weakness and disability after acute poliomyelitis tends to predict the development of post-polio syndrome. Patients who had minimum symptoms from the original illness will most likely experience only mild post-polio syndrome symptoms. People originally hit hard by the poliomyelitis and who attained a great recovery may develop a more severe case of post-polio syndrome with a great loss of muscle function and more severe fatigue. Literature says there are currently no effective pharmaceutical or specific treatment for the syndrome itself. However, a number of control studies they have demonstrated that non-fatiguing exercises can improve the muscle strength. What does the patient they complain of? They complain that number of steps which they initially used to take is decreasing day by day. The strength of the lower limb is decreasing day by day. They cannot stand for a long time. Earlier they had no hand-thigh gait, now hand-thigh gait is coming. There is fear of fall. Sometimes they fall, which initially was not there. They get fatigue, they get back pain, they get bending while walking more than before. Their feet, which were almost plantigrade, sometimes they start walking on the lateral side, or the gait starts getting deteriorating. When these patients they come, I advise them surgery. And the biggest challenge to that is the opinion discouraging them from undergoing surgery by saying you might be deteriorating after, you might get deterioration after the surgery. Somebody might be befooling you. Muscles which they die once in polio cannot be recovered. Do not get operated. Wear caliper, etc. etc. By saying these things, these people are discouraged for undergoing surgery. I say yes, muscles which die in polio cannot be recovered, but the bends they are there, which can be corrected. The limbs can be functionally aligned to make the gait more energy efficient. And positive benefit after the surgery is the number of steps in one go which they used to take increase. The strength of the lower limb also increase. They can stand for more time. The hand-thigh gait is no more, and there is less fatigue. There is less back pain. They are more confident. And polio surgery is mainly for functional improvement. It is a function, not the looks. And the basic principle is, if any object which is gravity friendly, they do not need any support to stand. Similarly, limbs, even if they do not have power, if they can be made gravity friendly, that can be big help. Dear friends, whenever these patients they come, patient knows and we also find it is the foot and ankle deformity which is most obvious, most apparent, seen, analyzed by patient, public, physician, surgeon. Knee is hidden but can be seen from all the sides like foot, ankle if extra effort is made like in this patient. Hip is mostly hidden from the eyes and mind of both the patient as well as physician and cannot be seen from all the sides. Dear friends, I think polio deformity correction is mother of all the deformity corrections because multiple lower limb joints they are involved. Might be both the sides they are involved, spine is involved. Along with the deformities, the muscles are also weak. And very big thing, no research or literature is there regarding their treatment. And this is dynamic worsening leading on to post-polio syndrome. One more thing which I like to highlight, that this surgery is very non-glamorous surgery, non-glamorous job like total knee replacement, etc. Rest of the specialties of orthopedic. It is a specialty of deformity correction, rather subspecialty of that. I like to discuss one of the case. He is a 27-year male, post-polio. He wants to walk without stick. What do? We do muscle charting, full length x-rays, 3D CT scan, find out which bones are involved, which joints are involved, how much soft tissues are involved, how much muscles are involved. Should we do acute? Should we do gradual correction? Part of that acute, part of that gradual, everything is to be assessed deeply. Then we take the patient to the operation theatre. We do flexor abductor release, we do lateral popliteal nerve palsy, tensor fascia release, and after that we do the supracondylar osteotomy, intertrochanteric osteotomy, and this is the final frame. The deformities are being corrected with the help of HEXAPOD. These are the X-rays. And dear friends, you can see in sagittal plane the limb has become straight. Also in the frontal plane, limb has been straight. This patient from this to this, and I think it's a big change in his life, and I am very proud that he could get such kind of results, in which this is only 1 year, and believe me, the results they start improving year after year, year after year. Why? Because the bones start getting adjusted to new environment. They start getting lowered. The soft tissues, they also start getting adjusted. And I have seen many patients which after 2 years, 3 years, 4 years, they start getting more benefits of the surgery in standing period and walking period increases. And socially you can find out so, that this patient cannot be even seen suffering from any kind of polio deformity. Dear friends, sorry, he is another person, 27-year male, who was earlier operated on the leg. Some lengthening was done a few years back. Look at the kind of hip he is having. And we did full length x-rays, AP as well as lateral. You can see the kind of hip, you can see the sagittal plane deformities, and This is during the correction of these deformities, trochanteric osteotomy, supracondylar osteotomy, and plateau reversal. We have brought him from this to this. In polio, all surgeries cannot be done in one. So, sequentially, after 1 year, 2 years, 3 years, the patient again can undergo surgery to improve. Like in this patient, the lens still can be adjusted by something doing on this limb or the other limb once he gets recovery from this after 2 or 3 years more. Dear friends, this is a very good X-ray which teaches so many things to us. He is a poliotic person, 28-year male, who sustained fracture the shaft of the finger. Anything can be done, plating, nailing, traction, anything. But I prefer ILIZAROV method and HEXAPOD method to treat this. Why? Because in a poliotic, there is most of the times flexion deformity of the knee, and I address by doing supracondylar osteotomy. We applied HEXAPOD to correct the fracture. We applied HEXAPOD to correct the deformity, the flexion deformity into extension deformity. These are the things which can very nicely be done with the HEXAPOD and ILIZAROV. Once you know the apparatus, its limitation, such kind of complex deformities, the same time which took to heal this fracture, in the same time we also corrected its deformity as well. Same bone, fracture at one side, osteotomy at another side. Both were dealt with ILIZAROV and HEXAPOD. Dear friend, earlier we used to treat only with the ILIZAROV. These are the patients which I'll like to show you, who were only treated with the help of ILIZAROV. You see, so severe deformities in which soft tissue, bony surgeries they were done. This is 1 year after the surgery. This is 14 years after the surgery. There is no caliper, no shoe, no stick. Earlier she used to walk with the help of a big stick, and she had never touched the ground with the involved load. This case is an inspiration to me that even after 14 years, she can load fully on the limb which is completely gone. And this has changed her life and also my life, in the sense I started believing that yes, this can be done. Instead of walking with the help of all the 4 limbs, she can walk with both the lower limbs. She is a girl who came far off from another country, and you can see both the lower limbs they are weak. It took me 3 days to find out what can be done. On inquiry and finding out after muscle charting everything, we found that our left lower limb was loading 0% and right lower limb was loading 30%. So we said, okay, we will treat your left lower limb, which is loading only 0%. And dear friend, once this was done, she could bear weight 80% from 0% to 80% on the left lower limb, and on the other limb it was 30%, and now the other limb is to be addressed. We can do supracondylar osteotomy and lengthening at the same time, like in this patient. You cannot even recognize which limb she is having, which is polio. Here, foot and ankle that was corrected along with the supracondylar osteotomy. One thing in polio has to be remembered. You have to see upwards. If you want to correct foot and ankle, you must see whether knees there in good shape or not. Otherwise, you can create disaster. Another 30-year-old male, hand-thigh gait, recovered. Another patient, you see how friendly they are with the ILIZAROV wound. And at this stage, if any varus, valgus, recurvatum, procurvatum, we can address that. Another patient who is having hanging lower limb, hardly any weight is being by this, whole of weight is being borne by this stick. And this is after lengthening supracondylar osteotomy. And these patients, I said, they require multiple surgeries at multiple levels. Another patient who is almost walking without hand-thigh gait, but the gait on this and the after treatment, they are entirely different. This gait is very energy efficient. Another patient, 8 years after, no caliper, no stick. You see, he is lifting up his lower limb with the help of hand. Hardly any muscle is there which can be transferred from this side to other side. No caliper, no shoe, no stick, 8 years after the surgery. And another patient, hardly any muscle is there. Completely paralytic lower limb is there. And you see, while using ILIZAROV only, his hand is off the thigh. If it is so, then it will remain. Otherwise, it will not. What I mean to say, before the removal of the ILIZAROV, hand should be off the thigh. Another patient, stick and deformities are there in the caliper. Flexion deformity you can see, shortening you can see. Still the caliper is there, but a gait in which caliper is there without the deformities of the knee, etc., is much better than a caliper with gait in which there are deformities of the limb. So dear friends, after using only ILIZAROV, then we shifted on to HEXAPOD. And for using HEXAPOD, we also started treating post-polio syndrome cases. And you can see in some patients, the HEXAPOD is still in place like in this. In rest of them, here also HEXAPOD is there. And in rest of them, it was used, and once the deformity was corrected, it was removed. And dear friends, we can correct the supracondylar osteotomy direction, etc. We can correct also soft tissues of the knee. We can correct ankle, we can correct foot. The whole lower limb can be corrected and put to a nice place so that he can walk much better than before. And these are after the no hand-thigh gait is there, limb is straight. Another patient, equinus is there with FFD of the knee is also there. HEXAPOD is still there on this, and here the heel is touching. Might be this gait and this gait in the video look almost the same, but this patient can stand for very long period. This patient can walk for long periods. He is another doctor by profession, who is having no hand-thigh gait, no caliper, no shoes, and this is about more than 6 years after the surgery. Another patient, hand-thigh gait, no calipers, no shoes, and it is more than 7 years now. She came from Bangalore to get treated at Kurukshetra at my institution. The carry-home message is post-polio syndrome is a very commonly seen entity, mostly neglected. It is undiagnosed, it is untreated entity, and it can be treated. Like in this slide you can see, as we see, there is no one in the corridor and no polios is there, no post-polio deformities they are there. We just watch and you see there are multiple patients. They have multiple problems. They are suffering from polio and they need to be addressed with very precise methods in which their lower limb can be oriented properly and they can benefit in their gait as well as standing postures. Dear friends, please listen to them in future. They all can benefit by surgery with any method, but I use ILIZAROV and HEXAPOD. And thanks a lot for your kind attention and my humble invitation to all respected orthopedic surgeons to please visit Polio and Deformity Center. Thank you very much, and I am also thankful to all these patients and their families who have deposed faith in me to get them treated. Thank you very much for listening to me and spending so much time to listen to my talk. Thank you very much once again.